Every American alive today has some relationship with health insurance. You get it through your job, you buy it on a marketplace, you qualify for a government program, or you go without it and hope nothing goes wrong. The system is so woven into the fabric of American life that it feels permanent, as though it has always been there, a feature of the country as fundamental as elections or public schools. But health insurance in America is not old. It is not a founding institution. It is not even a 20th century creation in any meaningful sense. The first real health insurance plan in the United States was invented in 1929, the same year the stock market crashed. Before that, for 153 years, the country had nothing. If you got sick, you paid for it yourself. If you could not pay, you suffered. And if the bill was large enough, your family went under. So how did the richest country in the world go a century and a half without figuring out how to help people pay for a doctor? That story involves a medical profession that actively fought to keep healthcare expensive, a hospital administrator who got the idea for insurance from a tube of lipstick, and a world war that accidentally built the system most Americans still use today. Healthcare before insurance looked nothing like what exists today. In the 1800s, going to a hospital was not something respectable people did. Hospitals were not treatment centers. They were charitable institutions, closer in function to poorhouses than to the gleaming medical complexes of today. In 1870, there were only 112 hospitals in the entire United States. They existed primarily to house the destitute, the mentally ill, and people with no one to care for them. If you had money or a family, you saw a doctor at home. The doctor came to your house, examined you, prescribed whatever remedy was available, and presented you with a bill. You paid in cash. If you were a farmer, you might pay in eggs or grain or a side of pork. The bills were usually modest because there was not much a doctor could do. Medical science in the 1800s was primitive by modern standards. Doctors set broken bones, delivered babies, stitched wounds, and prescribed medicines that were often little more than flavored alcohol or opium. Surgery was dangerous and rarely attempted except in emergencies. Anesthesia did not become widely available until the 1840s. Antiseptic technique did not become standard until the 1880s. A doctor's visit in the 1870s might cost between $1 and $3, roughly equivalent to a day's wages for a working man. For most families, that was manageable. But two things changed at the turn of the century that made the old system unsustainable. Medicine got better, and it got more expensive. Between 1890 and 1920, the practice of medicine was transformed by a cascade of scientific advances that made hospitals essential to modern treatment. X-rays were discovered in 1895, giving doctors the ability to see inside the human body for the first time. Surgical techniques improved dramatically with the spread of antiseptic methods and anesthesia. Laboratories could now identify the specific bacteria causing infections and develop targeted treatments. Blood typing, discovered in 1901, made transfusions possible and opened the door to surgeries that would have been unthinkable a generation earlier. Hospitals began installing operating rooms, diagnostic equipment, and sterile wards that bore no resemblance to the charity wards of a generation earlier. By 1900, hospitals were no longer places where the poor went when there was no other option. They were becoming the centers of modern medical treatment, places where diseases could be diagnosed, surgeries could be performed, and lives could be saved in ways that had been impossible 20 years earlier. And their services cost money that most ordinary families simply did not have. A hospital stay that might have cost $5 or $10 in 1880 could cost $50 or $100 by 1910 and several $100s by 1920. A surgery that would not have been attempted at all a generation earlier was now possible, but the bill for it could wipe out months or even years of a working family's savings. The gap between what medicine could do and what ordinary people could afford was growing wider every year, and no mechanism existed to bridge it. Americans were caught in a cruel paradox. Medicine was getting better, but the better it got, the less they could afford to use it. A family that might have paid $3 for a doctor's house call in 1880 could now face a hospital bill of several $100s for a surgery that genuinely saved a life. The treatment existed, the family needed it. But nobody had figured out a way to make the cost manageable. There was no mechanism to spread the risk of a medical emergency across a large group of people, no way to pay a small amount regularly in exchange for protection against a catastrophic bill, and no institution, public or private, that was working to create one. The medical profession was focused on advancing the science of treatment. Nobody was focused on the economics of paying for it. Some Americans did have a form of protection, though it looked nothing like modern insurance and operated on principles that the current healthcare industry would find almost unrecognizable. Throughout the late 1800s and into the early 1900s, fraternal organizations provided a surprising amount of medical coverage to their members, through a system that was simultaneously primitive and remarkably effective. Groups like the Independent Order of Odd Fellows, the Fraternal Order of Eagles, the Ancient Order of Foresters, and hundreds of ethnic, religious, and racial mutual aid societies operated a system known as lodge practice. The concept was elegant in its simplicity. A local lodge would contract with a doctor to provide medical care to all of its members in exchange for an annual salary paid out of the members' dues. The doctor was essentially on retainer, available to the lodge members whenever they needed care. Members paid their dues, typically $1 to $2 per year for medical coverage, roughly the equivalent of a single day's wages, and in return they could call on the lodge doctor for office visits, house calls, and minor surgical procedures without any additional charge. The doctor received a steady and predictable income, the members received affordable medical treatment, and the lodge served as an intermediary that gave working-class families a degree of collective bargaining power they could never have exercised individually. The economics were remarkably favorable for members. A non-lodge member visiting a doctor in the early 1900s might pay $2 or more for a single office visit. A lodge member paid that same amount for an entire year of medical care. The system worked because the lodge spread the cost of care across a large group of people, most of whom were healthy in any given year, which is exactly the same principle that modern insurance is built on. By the 1920s, at least 1 out of every 3 adult men in the United States belonged to a fraternal society of some kind, and lodge practice had become a major force in American healthcare. In the Lower East Side of New York City alone, 500 physicians were under contract to Jewish fraternal societies, serving tens of thousands of members and their families. In New Orleans, over 600 black fraternal organizations operated lodge practice arrangements during the same period, providing medical care in a community that was largely shut out of the mainstream healthcare system by racial segregation. The American Medical Association hated it, and the AMA's opposition to lodge practice was not a matter of quiet professional disapproval. It was an organized, sustained, and ultimately successful campaign to dismantle a system that was providing affordable medical care to millions of working-class Americans. The AMA saw lodge practice as a direct threat to physicians' incomes and professional autonomy. Under lodge practice, as the doctor worked for the lodge, not for himself. The lodge members elected the doctor, set his salary, and could replace him if they were unhappy with his services. The AMA argued that this arrangement degraded the medical profession, attracted only incompetent physicians who could not build a private practice, and undermined the principle that the doctor, not the patient or the lodge, should control the terms of medical care. The AMA's official publications warned against contract practice and urged physicians to refuse lodge contracts as a matter of professional ethics. The real objection, though the AMA rarely stated it so directly in public, was economic. Lodge practice kept medical costs low, often remarkably low, and the AMA believed that medical costs should reflect what physicians felt their services were worth on the open market, not what fraternal organizations were willing to negotiate. A doctor earning $2 per year per patient from a lodge contract earned a fraction of what he could charge individual patients on a fee-for-service basis. The AMA wanted the fee-for-service model to dominate because it put pricing power in the hands of physicians rather than patients or their organizations. The AMA waged its campaign against lodge practice through every lever of institutional power it controlled. Physicians who accepted lodge contracts were denied membership in local and state medical societies, which effectively barred them from hospital privileges, referral networks, and professional advancement. Medical schools were pressured to discourage graduates from entering lodge practice. State medical licensing boards, which the AMA influenced heavily through its network of local societies, used their regulatory authority to make lodge practice increasingly difficult to sustain. By the mid-1920s, the AMA had largely succeeded in dismantling the fraternal medical care system that had served millions of working-class Americans for a generation. The most affordable healthcare system in American history was destroyed not by market failure, but by organized professional opposition from the people who were supposed to be providing the care. The AMA was equally aggressive in blocking any attempt at government-sponsored health insurance. In 1915, the American Association for Labor Legislation, a progressive reform organization that had already helped pass workers' compensation laws in several states, proposed a model bill for compulsory health insurance. The bill would have covered medical care, sick pay, and a small benefit at the time of a family member's passing, funded by contributions from employers, employees, and the state. The plan was modeled on health insurance systems that were already operating successfully in Germany, Britain, and several other European countries. The AMA initially expressed cautious support for the concept, with its Social Insurance Committee praising the proposal as a step toward improving public health. But when rank-and-file physicians across the country realized that compulsory insurance might mean government oversight of their fees, government regulation of their practices, and a potential ceiling on their incomes, the AMA reversed course with startling speed and opposed the bill with everything it had. State medical societies passed resolutions condemning the proposal. The AMA's journal published articles warning that government health insurance would destroy the independence of the medical profession. The bill never received a serious vote in any state legislature. The most promising attempt at health insurance reform in the first half of the 20th century was stopped not by public opposition, but by the organized resistance of the medical profession itself. This pattern repeated itself for the next 3 decades with grinding predictability. In 1935, President Roosevelt considered including national health insurance in the Social Security Act, but dropped the idea when the AMA threatened to oppose the entire Social Security bill, including retirement benefits and unemployment insurance if health coverage was included. Roosevelt decided that Social Security was too important to risk, and health insurance was sacrificed. In 1945, President Truman proposed a comprehensive national health insurance program that would have covered all Americans regardless of employment status, funded through payroll taxes and providing coverage for hospital stays, doctor visits, and laboratory services. The plan was supported by organized labor and by millions of Americans who had experienced the financial devastation of illness firsthand. The AMA responded with the most expensive lobbying campaign in American history up to that point, hiring the public relations firm of Whitaker and Baxter and spending over $1.5 million to brand Truman's plan as socialized medicine. The campaign distributed over 100 million pieces of literature to doctors' offices, newspapers, and community organizations. Pamphlets warned that government health insurance would put bureaucrats in charge of your medical decisions, destroy the sacred doctor-patient relationship, and turn American physicians into government employees. The campaign worked exactly as the AMA intended. Public support for Truman's plan, which had been strong when the president first proposed it, eroded steadily under the sustained assault. The bill was never brought to a vote in the Senate. The AMA had demonstrated for the 3rd time in 3 decades that it possessed the resources, the organization, and the willingness to block any form of health insurance that threatened the fee-for-service model and the professional independence of American physicians. The richest country in the world could not figure out how to help its citizens pay for a doctor, not because the problem was unsolvable, but because the people who profited most from the status quo had enough political influence to prevent any solution from being implemented. If you're finding this valuable and want to see more deep dives into the hidden stories that shaped America, hit that subscribe button. We cover the financial history behind the systems and institutions you deal with every single day. Now let me tell you about the hospital administrator who found a different path entirely. In 1929, Justin Ford Kimball had a problem. Kimball was a former school superintendent and lawyer who had recently become the administrator of Baylor University Hospital in Dallas, Texas. He was not a doctor. He was a manager, and the management challenge he faced was straightforward and urgent. The hospital was struggling financially. Baylor's records showed the average patient owed the hospital more than they could pay, and the gap between what care cost and what patients could afford was growing worse every month. Between 1929 and 1930, as the Great Depression took hold and wiped out savings across the country, Baylor's average receipts per patient plummeted from $236 to just $59. The hospital was treating people who needed care and collecting only a fraction of what that care cost to provide. If the trend continued, the hospital would not survive. Kimball studied the hospital's billing records and noticed something specific in the data. A disproportionate number of the hospital's unpaid bills came from public school teachers, a group that was steadily employed at modest but reliable salaries. Teachers could not afford a hospital stay when they needed one, but their income was predictable and regular. They were exactly the kind of people who would benefit from a system that let them pay a small, manageable amount every month in exchange for the security of knowing that if they got sick, the hospital bill would not wipe them out. He reportedly found his inspiration in an unlikely place. Kimball observed that even during the worst months of the Depression, people continued buying small consumer goods like lipstick. He realized that if he could make the cost of healthcare feel like the cost of a small, routine purchase, something you paid for without thinking about it, people would pay for it willingly. The insight was not about medicine, it was about psychology and pricing. In 1929, Kimball created what became known as the Baylor Plan. For 50 cents a month, Dallas school teachers could prepay for up to 21 days of hospital care per year at Baylor University Hospital. The plan was simple, affordable, and addressed a real problem that teachers faced every day. Over 1,300 teachers enrolled almost immediately. The plan was a success from its first year. Other hospitals in Dallas noticed and began creating their own prepaid plans. Within a few years, the idea had spread to cities across the country. Hospital administrators who were struggling with the same problem Kimball had identified, patients who needed care but could not pay for it, saw the prepaid model as a solution that benefited everyone. Patients got affordable access to hospital care. Hospitals got a predictable stream of revenue. The financial risk of a major illness was spread across a large group of people rather than falling entirely on the individual patient. By 1933, 26 hospital service plans were operating across the country. The American Hospital Association, which saw the plans as a way to stabilize hospital finances during the Depression, began coordinating and standardizing them. In that same year, a Minnesota plan adopted the Blue Geneva Cross, a universal symbol of healthcare, as its logo. The plans came to be known as Blue Cross. By the end of the 1930s, Blue Cross plans were operating in most major American cities. A parallel development emerged in the Pacific Northwest, where employers in the logging and mining industries arranged monthly payments to physicians in exchange for medical services for their workers. These arrangements evolved into what became Blue Shield, which covered physician services rather than hospital stays. Together, Blue Cross and Blue Shield provided the two basic components of health insurance, hospital coverage and doctor coverage, that remain the foundation of the industry today. But it was World War II that transformed health insurance from a voluntary product used by a fraction of the population into the dominant form of healthcare financing in America. And it happened almost entirely by accident. Nobody planned it. Nobody designed it. It emerged from a series of wartime decisions that were made for reasons that had nothing to do with healthcare, and the consequences of those decisions are still shaping the American healthcare system more than 80 years later. When the United States entered the war in 1941, the economy shifted to wartime production almost overnight. Factories that had been building cars were now building tanks, aircraft, and ammunition. Unemployment, which had hovered around 15% through much of the Depression, dropped to near zero as millions of men entered the military and millions more were needed to fill their places on the factory floors, in the shipyards, and across the war production supply chain. The competition for workers was fierce, and employers desperately wanted to raise wages to attract and retain the people they needed. But the federal government had imposed strict wage and price controls to prevent wartime inflation from spiraling out of control. The Stabilization Act of 1942 and subsequent war labor board rulings froze wages at their existing levels. Companies could not legally offer higher pay to attract workers without government approval, so they found another way around the restrictions. They began offering fringe benefits, including health insurance, as a way to compete for employees without violating the wage freeze. A factory could not pay you more dollars per hour, but it could promise to cover your hospital bills if you got sick. The War Labor Board ruled that benefits like health insurance did not count as wages and therefore did not violate the freeze. The loophole was open, and employers rushed through it. Then came the decision that cemented the system in place. In 1943, the Internal Revenue Service ruled that employer contributions to employee health insurance plans were not taxable as income to the employee. In other words, if your employer paid for your health insurance, you did not have to pay income tax on the value of that benefit. This made employer-provided health insurance dramatically cheaper than any alternative. A dollar spent by your employer on your health insurance was worth more than a dollar added to your paycheck, because the paycheck dollar would be taxed and the insurance dollar would not. The tax exemption created an enormous financial incentive for both employers and employees to channel healthcare spending through the workplace. Employers could offer a benefit that cost them less than an equivalent wage increase. Employees received something of great value without paying taxes on it. The arrangement was so advantageous that employer-provided health insurance expanded with extraordinary speed. In 1940, only about 9% of Americans had any form of health insurance. By 1950, the number had jumped to over 76 million people, roughly half the population. By 1960, over 122 million Americans were covered. The employer-based system that emerged from World War II was never designed. Nobody sat down and decided that the best way to provide health insurance to Americans was to tie it to their jobs. It happened because of a wage freeze, a tax ruling, and the desperate ingenuity of employers trying to attract workers during a labor shortage. The system stuck because the tax incentive was too lucrative for anyone to give up, and because the insurance industry, the employer community, and the medical profession all had reasons to preserve it. But the system had a fundamental flaw that would take another 2 decades to address, and it was a flaw that was built into the system's accidental architecture. If your health insurance came from your employer, what happened when you did not have an employer? Retired Americans, people with disabilities, the unemployed, and the poor were left out of the system entirely. They were the people who needed medical care the most and the people least likely to have any way to pay for it. By the late 1950s, the scope of the problem was impossible to ignore. A congressional study found that 56% of Americans over 65 had no health insurance at all, and only 1 in 4 had anything resembling comprehensive coverage. Insurance companies, operating on a for-profit model, had no financial incentive to cover the populations that were most likely to need expensive care. The elderly, who used more medical services than any other demographic group, were the hardest and most expensive to insure, which meant they were the least likely to find affordable coverage on the private market. The system had created an enormous and growing population of Americans who were too old to work, too expensive to insure, and too sick to go without care. It took until 1965 for Congress to finally act. President Lyndon Johnson, wielding the legislative skills and political capital that had made him the most effective legislator of his generation, pushed Medicare and Medicaid through Congress over the continued opposition of the AMA. Medicare provided government-funded hospital and medical insurance for Americans over 65. Medicaid provided coverage for low-income Americans. Johnson signed the bills into law on July 30, 1965, with former President Harry Truman, then 81 years old, sitting beside him in Independence, Missouri. It was a tribute to the man who had tried and failed to create national health insurance 20 years earlier, and an acknowledgement that the fight for health coverage in America had been going on for far longer than the country cared to admit. The story of health insurance in America is not a story about a system that was planned. It is a story about a system that was improvised, piece by piece, decade by decade, in response to crises that nobody anticipated and with consequences that nobody fully understood at the time. The fraternal lodges created the first affordable medical care in the country, and the medical profession dismantled it because it was too affordable and gave patients too much control. A hospital administrator in Dallas invented prepaid hospital coverage because his patients could not pay their bills, and he got the idea from watching people buy lipstick during the Depression. A world war created employer-based insurance because the government froze wages and companies needed another way to attract workers. The IRS made the system permanent with a tax ruling that was intended as a wartime expedient and was never revisited. And the enormous gaps left by that accidental system, the elderly who could not find coverage, the poor who could not afford it, and the unemployed who lost it the moment they lost their jobs, were not addressed until 2 decades after the system was already locked in place. Every insurance card in your wallet, every premium deducted from your paycheck, every copay you hand over at the pharmacy counter, every explanation of benefits you have ever tried and failed to decipher traces back to a 50-cent-a-month plan invented by a school superintendent turned hospital administrator in Dallas, Texas, who wanted to make health care cost no more than a tube of lipstick. That was 1929. Before that, for 153 years, the answer to the question of how Americans paid for medical care was simple, brutal, and the same for nearly everyone. You paid for it yourself, in cash, on the day you received it. Or you did not get it at all.